Frontotemporal dementia is a group of syndromes linked to frontotemporal lobar degeneration, typically presenting between the 5th to 7th decades of life. It is characterized by proteinopathies, most commonly involving tau or TDP-43 proteins. Approximately 10 to 20% of cases follow an autosomal dominant inheritance pattern. The most common clinical syndrome is behavioral variant frontotemporal dementia, presenting with apathy, disinhibition, and compulsive behaviors. Patients often show loss of empathy, overeating, and executive dysfunction, affecting decision-making. Behavioral variant frontotemporal dementia may be associated with motor neuron disease, forming the FTD to MND spectrum. Primary progressive aphasia represents another major syndrome, with progressive language impairment as the core feature. The semantic variant causes loss of meaning of words, objects, and even familiar faces and emotions. The non-fluent or agrammatic variant causes impaired word production and motor speech difficulties. Other related syndromes include corticobasal syndrome and progressive supranuclear palsy with overlapping features. Behavioral variant frontotemporal dementia involves the medial and orbital frontal cortex and anterior insula. Semantic variant primary progressive aphasia affects the anterior temporal lobe, while non-fluent variant affects opercular frontal regions. Parietal lobe functions are usually spared in early frontotemporal dementia. Key genetic mutations include C9orf72 expansion, M, APT mutations affecting tau, and GRN mutations causing progranulin deficiency. C9orf72 expansion is strongly associated with behavioral variant frontotemporal dementia and motor neuron disease. Neuropathology shows focal atrophy of frontal, insular, and temporal cortices with neuronal loss and gliosis. Protein inclusions include frontotemporal lobar degeneration with tau in 40 to 50% and TDP-43 in a similar proportion. Pick's disease represents a classical tau subtype of frontotemporal lobar degeneration. Disease progression follows a prion-like spread of abnormal proteins across neural networks. There are currently no disease-modifying therapies, and treatment remains symptomatic. Selective serotonin reuptake inhibitors are used to manage depression, compulsivity, and behavioral symptoms. Antipsychotics should be used cautiously due to risk of worsening Parkinsonism. Progressive supranuclear palsy presents early with falls, executive dysfunction, and vertical gaze palsy. Motor features include axial rigidity, slow gait, dysarthria, and dysphagia. Pathology shows 4-repeat hyperphosphorylated tau with tufted astrocytes. Levodopa provides limited benefit, and management is mainly supportive. Death typically occurs within 5 to 10 years from onset in progressive supranuclear palsy. Corticobasal syndrome presents with asymmetric rigidity, dystonia, myoclonus, and apraxia with alien limb phenomenon. Disease progresses to bilateral involvement with dysarthria, slow gait, and frontal predominant dementia. Corticobasal syndrome is a clinical diagnosis, while corticobasal degeneration is a pathological entity. Clinical takeaway is that frontotemporal dementia presents with early behavioral or language changes, distinct anatomical patterns, and lacks disease-modifying therapy.